Good evening. Thank you for tuning in. Hopefully, most of you had your dinner. If not, I'll make this brief. I'm here for half an hour to really talk about general infertility. My name is Dr. Samuel Su, and I've been a doctor for 23 years, and in the space of fertility treatment, probably 15 years. And I did a lot of my training. Started off at Monash University, where I did my primary degree, and really that got me interested as a medical student in infertility. Been privileged to work at Monash, followed to Royal Prince Alfred, where Sydney IVF, or Janaea was at the time, then the Westmead Fertility Centre, and then back to Melbourne, back home, where I grew up. And it's a real privilege to work for Melbourne IVF and here at Epworth Freemasons. And my practice is here at East Melbourne and in Box Hill, and we're talking about general fertility today. So please welcome to send messages, and I've seen a few, thank you. And if you've got any questions, please post them. I hope to get through maybe 15 minutes of talking about general infertility, and maybe the last 15 minutes to go through some of the questions as they pop up. So in terms of general fertility, it's a very broad topic, and we could be here for weeks talking about this, but so we'll try to cover things generally speaking, in general, whether the causes of infertility, the treatments that are available, and then move on from there. So let's start off by talking about why we're not falling pregnant. And the majority of causes can be quite simple, and some of it is very, very difficult to manage, and everybody else is somewhere in between. So with getting pregnant, generally we will find a couple under the age of sort of 37, 38 will take 80% will get pregnant in a year. And that's really the 20% that don't get pregnant is where we sort of start to have to, manage, indeed what is the problem. And the problem often, we sort of break it up into a male and female situation. And we do, being gynecologists as we are, and a lot of the problems are not just about getting pregnant, but avoiding miscarriages and making sure that pregnancy progresses well all the way to birth, really, because that's our aim. It's not just to get patients pregnant, but to really sort of have a healthy baby, and that will be the main aim. So let's start off with some of the known female problems, and then we can talk about some of the things that we can manage. So commonly, we break it down into things that are more lifestyle related, things that are more gynecological related, whether it's a medical gynecological problem or a surgical problem such as endometriosis or fibroid. And then we've got an area of where you might have less eggs that you would expect for your age. And then management and the investigations will then sort of focus on those things and to see whether that's a big factor or not. And in terms of the male, of course, the sperm is the big issue. And ultimately, we will respond to what the sperm count is, whether there's an underlying medical disorder that the male may have, and then look at possibly reversing some of those problems. And again, it also comes down to lifestyle. So lifestyle in general, it's got to do with being healthy, and we all know that. And then, and we shouldn't forget that that's probably one of the most important things. For example, sleeping well, eating well, managing your stress. And we all have stresses, from work to life in general. And things that I would like, patients to sort of think about is during the times of trying to get pregnant, it'd be worthwhile just to eat well and avoid too much junk food and too much processed food, and really try to be, eating well. Second thing is getting sleep. We often forget that sleep is an important part of our lives, and it can affect not just how your body functions. And we know that when you don't sleep well, your sugar levels are higher, you have a higher blood pressure, and so on and so forth, and you can't concentrate on work, for example. So sleeping well is the next thing. And just generally stress levels, going back to stress levels, there are things you can do that you can possibly meditate, or even doing fun things from time to time, and that would make a big difference. In terms of being a bit more specific, for example, talking about exercise and getting regularly into sport, making sure that you have the right amount of vitamins, that you have a balanced diet, and really drinking plenty of water throughout the day. And avoiding too much of this sort of soft drinks and so on and so forth. Or, I mean, one glass of coffee is fine, but having 5 a day was probably a problem. So going on to investigations, and what do we look for as fertility specialists? Well, a lot of it is guided by what initially the problem is, and we will take a history, examine the patients, and try to work out if we can get a clue from the initial visit that we have with you as to where some of the investigations will take. Generally, if nothing seems to be too obvious, we would look for, in the female, is there a anatomical problem like a fibroid or the risk of having endometriosis or an unusually shaped uterus? Are the fallopian tubes working? Is there a risk that it isn't? And also we look at some of the medical things. Are you ovulating? And there are some common conditions such as polycystic ovaries that may lead to a non-ovulating month, and that would say if you ovulate less throughout the year, you would therefore find it harder to fall pregnant. And then there's some general medical conditions we look at such as thyroid, and whether there's any sort of inflammatory diseases such as arthritis or thyroid issues or so on and so forth. Same with the male. I mean, when we see a low semen analysis, we wonder whether it's just a bit of a bad day for the partner. So often it's quite common for us to repeat the test. And indeed, if the sperm is a really, really low count, then it's often be a sign of something else that's a bigger problem. And we'll have to go on and investigate that further with more blood tests and ultrasounds and so forth. In terms of treatment for infertility, it is pretty much guided by what we find. But let's just assume that we don't find too much and your egg count is pretty good. What do we do next? I would like to say we do things that are relatively simple, and we track the cycles, meaning we'll try and find out when you would ovulate and try and encourage having sex. And that's the other thing. If you're not having sex often, it is harder to fall pregnant. And often one of the misconceptions, pardon the pun, is to have sex once during the month because I've got to save up all my sperm and this is the day we're going to do it. And that's actually probably the wrong way to get about it. The best way is to have sex several times over a week where you are most fertile, a few days, even up to 5 days before you think you ovulate, to well past the days that you ovulate. This gives you the best chance of getting pregnant, for example. Now, so I've got a few questions, but I'll come back to them in a minute. So in terms of looking at, questions about, do we do more after that? If you're not ovulating, why you're not ovulating, and some of the medical treatments we need to sort of manage there. And that's one section of the big problem with getting pregnant. Now, let's just assume that we've managed to get you to ovulate and the sperm is not too bad. What are the next steps, and why aren't people falling pregnant? I mean, everything looks good. You've got good sperm, you've got good eggs. Well, sometimes there are things that are not obvious. For example, the tubes may be blocked, and there are tests for that. But even the tests such as ultrasound or X-ray to look at the tubes may not be accurate. Sometimes there might be some sexual dysfunction, meaning that it's hard to hold an erection, it's hard to ejaculate, and these are the things that we can often help with. Now, moving on, and if you tried, let's just say we've been trying for a little while to fall pregnant, and we are tracking your cycles, you are ovulating, you're having the course at the right time, yet still some patients don't fall pregnant. What do we do next? Well, next would be, whether it's an intrauterine insemination, for short IUI. There's laparoscopy, where it's keyhole surgery, where we'll look for the problems to see if the tubes are working. Is there endometriosis? We could do a hysteroscopy to look at the shape of the womb and look at the lining of the womb, because you might make an embryo, which is where the egg and a sperm fertilizes, but it might arrive in the uterus and it may not stick, for example, and what is the reason behind that? And it could be related to an abnormality in the lining of the womb. It could be an infection. So a laparoscopy and hysteroscopy is a good way to look at the problem. And besides looking at it during that sort of surgery, we can often fix the problem. For example, it's well known that if you've got mild moderate, even severe endometriosis, that if you do the surgery well, the chance of falling pregnant is increased post-surgery. And we do achieve quite a few pregnancies from that through our practice here. And some fibroids may be a problem, may not. And again, that's something that we have to assess with ultrasound or even at laparoscopy to sort of work out what it is. Then, of course, there's IVF. And IVF is sort of one of those things that when you first, think about, okay, I can't fall pregnant. I hope that, when I see the doctor, the first thing they say is that I need IVF. Well, it might be the first thing that we say, but it may also often the last thing that we say. I would say probably more than 50% of my patients fall pregnant with quite simple things, with follicle tracking, with making sure you're ovulating, with making sure intercourse is the right time. And then the other 50% may need laparoscopy or indeed IVF. So IVF, it's been almost 40 years of it now, and I think we're very fortunate in Australia that I can say we are probably world leaders and have been for a good part of that 40 years. And we're very fortunate in Victoria to have several good IVF centres. And while I'm at Melbourne IVF, of course, I'm biased and to say that we're one of the best, but I would say Monash is, always been a good competitor, and I have many friends that work there, and they're a good unit too. So I might, cognizant of the fact that we've now spent half the time talking a little bit more general about infertility, and maybe I can get to some of the questions. So the first question I had that was sent earlier on was, in the presence of a low sperm count, for example, 10 million, and a normal is usually greater than 20 million count, and the second issue here is also reduced motility, whether intrauterine insemination can be used. Look, I think it depends on several things. Firstly, I would like to know that intercourse is not a problem, because I think if you have a bit of sexual dysfunction, meaning that you don't think that you can ejaculate during the course, or you're not ejaculating at all, then during intercourse, then IUI may be something you could try. But indeed, if there's no sexual dysfunction, I find that with a low sperm count, and it's definitely on a repeat test that is the case, I think IUI is less likely to work. But certainly, if IVF is sort of a bit out of reach, or seeming a bit foreign to you at that point, it's certainly not a problem to try IUI, and your chance of falling pregnant would be a little bit higher than you would otherwise. I must say, though, I think a lot of the success of IUI in general, even if you have a normal sperm, is from us doing follicle tracking. And follicle tracking is where we sort of follow the growth of the the follicle up to a certain point, and we know when you're going to ovulate. Now, we can pinpoint that time, then that's when you would do the IUI, meaning that's when we'll put the sperm through the cervix into the womb, and this sperm is prepared. I think a lot of the success of IUI has got to do with follicle tracking. Hence, in my practice, we follicle track patients, but we encourage patients to try sex for several months before thinking about things like IUI or laparoscopy as IVF. Generally speaking, we hope to help you and not do much, and hopefully you get pregnant. And because it's inexpensive, it's not too time consuming, it's not painful, it's not costly. But it comes to a certain time where you're 3 or 6 months seeing us, you're frustrated, and sometimes we do have to do the more invasive things such as surgery and IVF. And these things are more costly, they're more painful, but at the same time, they are more likely to work, and hence sometimes we need to do that. So hopefully I answered that question. I had a general question about, ovaries, do they ovulate alternately? Meaning that I guess from that question, sometimes it comes 1 month to the left, 1 month to the right, and back again. Actually, no. From my time from follicle tracking, and not many textbooks have this answer, but from my time of follicle tracking, maybe now for 15 years, I find the ovaries are a bit random, which ones they ovulate. It's kind of flipping a coin. One of the reasons is ovarian tissue, even though you have 2 ovaries, the brain sees it as one, okay? And so it doesn't really matter as a left or right thing. You can really treat them as one entity. And really, I suspect that why human beings have 2, and if you believe in evolution, it's probably because if something happened to one, you still have the others. Probably the same reason why we have 2 kidneys, 2 lungs, so on and so forth. So I would see that some years that, we'll say the same patient that she will keep ovulating from the left, and then certain years will ovulate from the right. Probably fair to say, though, if the ovary is a bit larger on one side, it'd be fair there's a larger ovarian reserve, so you might find that you might ovulate more from there. You might find that you had a cyst removed years ago from one ovary, and when you remove a cyst, and sometimes if you're not careful and you don't do it properly, and I've seen that a lot, that ovary is too far damaged and it doesn't ovulate as much. So an important thing to do about cyst and surgery really, at one point, is to remove that, but the second point is to ensure that fertility is preserved in that ovary. So I've got another question here. It says, look, my partner has a low motility but has 70,000 sperm count. What options do we have to conceive? Now, firstly, I think, Anna, the important thing is to figure out why the sperm count is so low, because the most important thing is to make sure that your partner doesn't have a brewing cancer, for example, a lump or something like that. And with such a low sperm count, one of the things we need to do is make sure that an ultrasound is done and that there's no masses. Now, at the same ultrasound, sometimes they pick up issues like a vein that's a bit enlarged, or that maybe the testicles are very small, and that may be a symptom of an accident that happened years ago. For example, if the testes were torted, meaning twisted at a young age, or you played a lot of sport and had a lot of trauma to the testes, and they've been damaged over time, that could be the case. Now, there's also sometimes a condition whereby when the brain speaks to the testicles, sometimes the feedback loop is a bit confused, and there's not enough information or hormones that's going from the brain to the testicles. And so you'll need really some hormone profiles done to make sure that that is not the problem there. And rarely is it correctable, but sometimes it can be. So let's just assume we've done all these tests and everything is normal, and you're still left with a really, really low sperm count. Well, look, I've had a few patients fall pregnant naturally with a very low sperm count, but not many. And this is one of those indications where, IVF is what you need to do. And during the IVF, with such a low sperm count, we will need to do a special kind of IVF where you actually inject the sperm to the egg. Okay, so IVF is there are many types, and generally speaking, we would collect an egg and throw some sperm at it, and then during the course of the night, you will see fertilization the next day. But with such a low sperm count, it's almost no point doing that. What we'll need to do is IVF with ICSI, where it's intracytotoxic sperm injection, where we basically will hold on to the egg and find the best sperm, the one that's moving the best, that looks normal, activate the sperm and really inject it into the egg to try and promote fertilization. Because at that low sperm count, even standard IVF will not work. So we need to do ICSI, and that should overcome that problem in most cases. But we really, just to reiterate, we need to make sure we have all the tests done to exclude any possible causes before we move on to IVF. Okay. My next question here is how efficient is IV, the artificial intelligence for embryo selection? I have my embryoscope here, and it's possible to scan it for selection. Okay, so thank you for asking the question. I mean, artificial intelligence is something that Virtus Health, or in this case Melbourne IVF here in Melbourne, have really pioneered around the world, and we have been getting success from it to the point where we're probably going to introduce it right across the board in the coming months or maybe a year. So what is artificial intelligence? Okay, so before artificial intelligence was invented, we basically seen the growth of embryos by looking through a microscope. And in the past, we would check it at different parts of the age of the embryo. So, the day following egg collection and IVF, we would see how many is fertilized. We'll then check it on day 2, and used to transfer a lot of embryos in day 2. Certainly when I started working, that's the majority of our practice. But over the last sort of 7-8 years, we moved on to day 5 and we transfer. And the selection of the embryo really is based on the experience of the scientist and what we've learned in the lab as to what the best is. And it's not just on day 5 what it looks like. It's really about the whole development phase. Now, several years, about 5-6 years ago, I think now Melbourne IVF was one of the, if not the first, if I'm not wrong, IVF Centre to have an embryoscope, and we were experimenting with it. That gave us a new way to look at embryos. Embryos could be seen 24/7 from the day it leaves the human body to the day that we put it in. It's videoed 24/7. And that gave us an opportunity to then say, well, is there a better way of selecting embryos instead of taking them in and out of the incubator to try and, at certain points on day 2, day 3, or day 5? Is there something along the way that will give us a better result? Trying to put the best embryo first is really where artificial intelligence comes into it. And so we ran a trial where we basically, with the embryoscope, allowed to see the growth of the embryo over 5 days. And by setting the parameters, we were able to potentially pick up. The idea was to pick up the best embryo. So we then compared, patients that had the traditional assessment of the embryos by the most senior scientists versus the AI. And at the moment, the artificial intelligence is winning a little bit. And of course, we've got more research to do. But the general feeling among scientists and ourselves here at Melbourne IVF is artificial intelligence is going to be something of the future. And a lot of our patients now, we choose the embryo through artificial intelligence. Okay, so how would IVF or IUI work with someone who has PCOS and endo who has been trying for 3 years to fall pregnant? Okay. So it's a complicated question because, polycystic ovarian syndrome is where you have many follicles in the ovaries, and as a result of that process, you may not ovulate every month, and you'll have the syndrome if you take more than 1 month to have a period, for example. So commonly, it could take 40 days, 50 days, 6 days, or even not ovulate for half a year, right? And so the first thing we need to do with that sort of problem is to deal with the PCOS first. And we will have to make sure that you're ovulating, and that could be meaning tablets such as clomiphene or letrozole. And in some cases, you might need FSH injections to get you ovulating. And it's interesting that around the world, very few places will be doing injections with FSH, which is follicle stimulating hormone injections, because it's actually really expensive. It's about $1,500 just for the pens to do the injection. But in Australia, we're very fortunate that the government support ovulation induction by covering most of the costs. So the pens cost you about $40, $50, $60. So we do a lot of ovulation induction sometimes with the injections. These are the same injections that we use for IVF, but at a lower dose, and try to make one follicle at a time. Now, I would say that the first thing I would do if you have PCOS and endo is to really try to get you ovulating. And if you're ovulating for 3 or 6 months, it's proven on ultrasound, and you are ovulating and you're having sex and the sperm test is normal, you should be pregnant. And in actual fact, if you had PCOS and you come and see me during an audit recently, more than 3/4 will be pregnant naturally. But of course, if you're in that quarter where you're not falling pregnant, then we have to start looking further as to what some of the causes are. For example, it could be endometriosis, as you brought up, and endometriosis is a cause of infertility. It's more so known now in 2020 than even sort of 10 years ago. I mean, I remembered when I was a young doctor in gynecology and been told several times that endometriosis does not cause infertility. But I worked with several doctors who were very interested in endometriosis. One of them was Michael Cooper in Sydney, among others. And it was pretty obvious when research came out that if you treated endometriosis properly, and so you've had high quality surgery, that the result for endometriosis following endometriosis surgery is better. And so in your case, I would treat the PCOS first, and if you're ovulating for 3 to 6 months and you're not pregnant, assuming that the sperm's normal, and you've known you've had endometriosis, then it's worthwhile to have a look at that, whether you have more surgery. Sometimes endometriosis could have caused the tube to be blocked. So, if you're not falling pregnant, following several months of ovulation induction, I would probably look at having the endometriosis treated and then moving on from there. Now, sure, I've got patients with PCOS and endometriosis that even despite all the things I've done for them, not pregnant. And I think, the frustration will set in. I think IVF is probably where you would go, if you've been trying for 3 years and you've done all those things, okay? But of course, along the way, we have to make sure everything else is done properly as well. So I've got a question here. I'm 8 days post-transfer, and I did a home pregnancy test. It was negative. Is it possible still to get a positive at day 14? Yes, it is still possible. and hence we usually wait to the day of where it should be, because I've had patients with moderately low HCG, and the experience that I've had initially was that these patients won't do well. And however, more recently, from our knowledge that has come from managing recurrent miscarriages, is that some patients do start off with a low HCG, and we can support the HCG. We can support the pregnancy with the low HCG levels with several other hormones and treatments that are out there, and often sort of get to a normal pregnancy. I mean, I delivered a patient maybe 2 months ago, and she might be here watching today, and she did remind me at the cesarean section that I said, "Oh, congratulations, the baby looks great, and I'm so happy for you." And she looked at me, I'm so happy too. Do you recall, Dr. Sue, that my HCG was low at the start, and you were quite negative, and you told me that the pregnancy not going to continue. So I've learned a few things, probably to be a little bit more conservative in the way that I counsel my patients, but I'm really happy that she did well. And there are some things that are a bit experimental that we try to try and improve the early pregnancy losses. I think that's probably made a big difference to some of our outcomes in the last few years. I hope that answered your questions, but I would certainly wait to day 14 to do your blood test, or day 10 after transfer anyway. Okay. So how is IV efficient in selecting embryos in Laparoscopy? I think we've talked about that. I mean, it's efficient, meaning that it is artificial intelligence. And if you had a busy laboratory or lots of scientists, and there could be human error. I mean, we're all humans at the end of the day. I mean, we all make mistakes. I make mistakes, but it's about minimizing mistakes and putting systems around you to try and minimize the mistakes to almost as close to zero as you can get. And I think IV is one. IV, which is the artificial intelligence name that we've given. Sorry, I should have said that. Will give us an opportunity to improve workflow, so the scientists can maybe spend more time with trying to get, the fertilization better and doing the jobs a little bit better, because they have more time. And IV, basically automizes the system in such a way to get us there. I hope that answered your question there. Why does someone in the same age range has different AMH levels? Someone getting 5 versus 39, for example. Well, Amanda, it really, at the end of the day, it just comes down to the fact that we were born a little bit different, and some people are born taller, shorter, so in terms of the ovaries, it's something similar. Okay, and that's why, for example, if you and it's a bit familial, meaning that if there is a mother to daughter or even father to daughter relationship, I think if your mother at PCOS, there's a higher chance that you might have it. And PCOS is a situation where you have a lot of eggs, to the point where sometimes you're not ovulating, so your AMH level could be very high, and that would be a familial kind of inheritance there. Secondly, some patients may have had surgery to the ovaries where a cyst was removed. Some patients may have lost an ovary. For example, ovaries have been known to tort and turn and die off, and that's a surgical emergency, but that's sometimes missed. Okay, and sometimes there's a medical condition that has resulted in the ovaries being damaged over time, and endometriosis is probably a large factor. So if you have endometriosis attacking the ovary over time and it's not treated, then the egg count will drop off. So we're all using the analogy of being born in different heights. So some women are born with AMH and egg counts are really high, and some people are born at this point. Okay, and over time you would sort of come down to a point where you hit menopause. Okay, so that is why there is a range of different AMH levels. Okay, hope that answers your question. And that's sort of so the same age group you can get that. PCOS has a high AMH age. That's correct. I have a low amount of eggs as well. 20 in the left and 23 in the right. I have a low amount of eggs as well. How would that affect my chances? That sounds like a high number of eggs. Amber, I think that's going back to the PCOS. Okay. Well, I think at the end of the day, first, the most important factor of infertility is age, and maternal age is a large factor. Like it's over sort of much more important than paternal age, the age of the male. But the age of the male is a factor too, but much smaller. So if you have 20 and 23 eggs, then you do, and you're not ovulating, then it sounds like you've got PCOS, and that needs to be managed, and we have to make sure you're ovulating. Okay, how would that affect my chances? Well, I would look at the bright side. I think it's probably better to have more eggs than less eggs. With more eggs, there are a lot more options to get you there, and I'm much more confident in getting patients pregnant when they have a high egg count than a low egg count. So I hope that gives you some confidence into what you do next. Okay. Would you recommend changing specialists after multiple failed cycles? Of course, you should come and see me. No, I mean, jokes aside. As a single woman who has never tried to get pregnant, I think it's a difficult thing is whether you change fertility specialists or not. I think, I've had patients come to see me, over 50% of my patients are second opinions, and it's probably a sign of me being around for a long time. I mean, I've been practicing fertility in Melbourne for 11, 12 years and really 15 years. So I do get a lot more second opinions. So I understand it. And I've had patients who, felt that we haven't done our best, it's gone elsewhere. And that's fine. I think it's important for whatever patients that most of us fertility specialists don't get upset. We understand that it could be a whole lot of different reasons that, we're not getting along, or you're feeling you need a second opinion. And I encourage people to do that. You might find the opinions the same often. Sometimes you may not, and sometimes you get a world of different opinions, and that's because infertility treatment is broad, and there are many ways to get people pregnant. Okay, and the way that I've talked about is pretty much what most of my colleagues would do, but I've got certain things that I feel strongly about, and certain things I don't, and I normally lay that out pretty clearly with the patients that I would say this, and 95% of my colleagues will say the same, or that I would say, look, I've been in this area a little bit longer, and these are some of the things that I agree or disagree on. So I hope that helps answer your question there. Is level 25 considered high for natural killer cells? That could be the cause of early miscarriages. So the 25, I'm not entirely sure exactly which part of your cycle, because that could change, but let's just assume that you've been told it's high and it's the cause. So natural killer cells, really it's been around for 10, 15 years. I mean, I've heard about it since I was a junior doctor, and it's one of those things. It's either popular or it's not. 1 year's in vogue, 1 year is not. And I still do natural killer cells. I was more likely to do it 3 or 4 years ago, but less likely now. I think early miscarriages is complicated, and there are many other things that you should do, but natural killer cells is one of them. The problem with the treatment for natural killer cells is complicated, and a lot of the research have shown that some treatments work and some don't, and it's quite contradictory. And some of the medications used for that can sometimes harm the fetal development, so we've got to be a little bit careful. So we have to put it in context of everything that you've done. And if you're looking for a silver bullet and say, that is the reason why I'm not falling pregnant, well, yes, sometimes when it's simple, but sometimes when it's complex, there's a whole large, varied number of reasons that we have to fix each and everyone, including natural killer cells that are present, whether in the blood form or in terms of the lining of the womb, needs to be treated. Question, both age 32, partner has low sperm motility morphology. What options do we have to get pregnant? Look, again, it's got to do with why you've got a low sperm motility, and I would get it checked a few times and making sure that the scans and blood tests are done, and the hormone levels are checked, and these things are potentially managed. If the sperm continues to be very low and you've been trying for at least a year or two, at least a year, I think, unfortunately, in this case, really IVF is kind of what you're left with, and that's probably where I hit. And IVF is something that I always think of last, but I must admit, a good third of my patients that I look after do end up going there and having to need IVF to get pregnant. Okay. How do you make egg quality better as I have gone through 5 unsuccessful cycles? Yeah, that's a tough question. Look, at the end of the day, it is very much related to age. And, the older you are, the harder it is. And that's something you can't change, so I won't harp on about that. So egg quality is to improve egg quality, there's several things you need to do. And you go back to lifestyle, right? And all the lifestyle things that I've talked about, they're really important. So we would do that first, okay? The next thing is, what do we do to improve it better? And the way I look at fertility treatment is such that there are things that are known for sure, and I put it in a circle here for patients to say, these are the things that we must do. And these are the things that are proven over time. And then there are things that sit outside that circle, and another one that sits out of the circle, meaning that there are things that are not necessarily proven, research is not sure, but I have a personal belief from my experience that this is what we should do. And it's got to do with supplements, possibly, or combs. Q10 is one of those things that I like to use now, and there's increasing evidence that that's improving. So these are some of the things that patients can do, right? And then moving on, now, how do you know you have a poor egg quality? Is it because your IVF success rate is not good or the embryo quality is poor? But remember, we still have sperm, and sperm is sometimes it's hard to quantify how good or how bad it is. And from the egg to the embryo, you've got a laboratory that really, a good laboratory is really, really important in giving you the best outcome. And I'm glad to say that I'm still at Melbourne IVF, and I'm probably going to be here till I retire, because up to this day, the laboratory has been one of the shining light for us here at Melbourne IVF, and I'm really proud of some of the things that they've done and are doing and planning to do over the next few years to significantly increase pregnancy rates. And when the pregnancy rates are published later this year, you'll see that just in the last 5 years, Melbourne IVF has improved. So the laboratory is really the next more important thing. Now, the last thing, and also importantly, sometimes is how the eggs are stimulated during the IVF. There are different medications you can use, so on and so forth. Then further afield, I'm a big believer that your endometriosis needs to be fully treated, in this case, when you've got poor eggs, because that could be a cause. It's a cause. And not just treated, it needs to be treated with high quality surgery with a well-known endometriosis surgeon, or a surgeon that can promise to deliver high quality surgery. And then that's really important. Okay. Do you have patients who does IVF and then on 3 months of Zoladex, the string uterus then transfer? What is the success rate? Yeah, look, I do, not many. I suspect that's probably because of my endometriosis. And you might have adenomyosis, which is a kind of endometriosis that affects the womb. And if you've had multiple failure or transfers, that may be a good idea to try. I find Zoladex and then sort of waiting for 3 months, it does take up some time. So sometimes I find it difficult to encourage patients to do that. So I don't do it often, but I do it in certain patients who I'm having trouble getting pregnant, and I can't really improve that. How would you go about getting a transfer from one IVF company to your company? Oh, look, it's very straightforward. While we're competitors, we're all friends. I mean, the scientists from all the companies, they all know each other. It's a small community. A lot of my very, very close friends work for other IVF centers, and it's not like what you think. It's quite simple. You just have to inform them that you're seeing someone else. Generally speaking, you should meet the doctor first, get an appointment, have a feel of what you want to do, and then discuss where your embryos are and what it brought over. And there is a small fee and a couple of forms to sign in, and it's sort of sorted. So is laparoscopy the best way to identify second infertility, endo-infection tubes easily cleared during surgery, successful outcomes? Thanks, Rebecca. Yes, look, certainly, laparoscopy is really the main. It's been around for a long, long time, and it's well studied, and it's a procedure that is safe. But there are some risks, and you've got to do it safely. Okay. So what are some of the causes of secondary infertility? Well, commonly it could be endometriosis, it could be a tube that's blocked, okay, and it could be a uterus and lining of the womb that's affected. So by doing surgery, it gives you an opportunity to assess what the problem is and go ahead and fix it at the time, okay? And that's because we still we don't call ourselves IVF specialists, even though I'm an IVF specialist, sure, because I do IVF and it is a specialized area, but we'd like to call ourselves fertility specialists because we're about getting you pregnant, and we don't mind how you do it. And ultimately we hope that getting pregnant naturally is really the main goal. Okay, and hopefully that you get pregnant naturally. And laparoscopy is one of those things that will help you achieve that goal. But of course, at some point after laparoscopy, if you're not pregnant, then it's IVF is what we'll look at. I've got a question here that I have a translocation. We're doing IVF cycle with a female donor. 2 embryos were fine. Second embryo, should we move to sperm donor? Well, that's a tough question. I think I can't really answer it in sort of the format we have today. I think this is one of those things where we really need to look at everything that's happened so far. Where are you now? And exactly what the embryo quality was like and what was done. And then move on from that. Because sometimes it's not just about the embryo. Sometimes it's about the lining of the womb, whether it's likely to receive the embryo, and there are a lot of things that can affect it. So I'm sorry I can't really elaborate more about that, but I think rather than one single problem, it's going to be a whole lot of things that need to be reassessed before you decide to do a sperm donor, because that's a big decision. What would be the cause of 2 out of 5 embryos not surviving thaw? That's unusual, Kate, and if that's happened at Melbourne IVF, I'm really sorry if that's the case. I would say if you had 5 embryos frozen, we would expect that Melbourne IVF, or in my patients, that at least 4.5 out of 5 embryos, and don't quote me on that, but it'll be close to 4 to 4.5 embryos, meaning 80-90% of the embryos should survive for transfer. Okay, so I'm not too sure what that was done, but again, have I seen it? Yeah, look, I've had a patient where she had 5 embryos frozen and 1 didn't make it, and sometimes that could be an indication of something that has gone wrong in the laboratory, and these things are well documented, and so all the different all the different media, for example, test tubes, incubators, and so they will go back and look at these 5 embryos that you stored and look at all the other patients on that day that were treated, and look at all the embryos that were frozen that day, and then come forward and say, well, how did they do? If they have done well and you have stood out as being abnormal, then it's really not a laboratory problem at that point, but more so a bit of bad luck. Okay, but if this, if you have 5 embryos frozen and only 2, and that's a repetitive problem, it probably could be an indication of something else that needs to be looked at. So I'm sorry I can't elaborate on that, because there are a lot of causes for that, but hopefully that gives you a bit of understanding of what's going on. Is there anything to do or eat during a stim cycle? Is it okay to continue taking CoQ10 and other supplements? Absolutely. I would think you should eat well. Try to minimize any junk food, or and try to eat fresh food, and try to eat widely. And that's how I would look at food. From to your vegetables, to your protein, and your carbohydrates, just keeping a good balance and making sure that you've got a balanced diet. I think that's really important. Okay, and I would taking coenzyme Q10 is certainly a reasonable thing to do. Okay. All right, I think we're a little bit past the time, so I'd like to thank you all for tuning in, and it's been an interesting first time for me to do this. As you know, I've hardly I'm not someone that does social media, but I think it's been good to be able to interact with the questions that you had. I hope I've done my best to answer your question. I do, however, like the last question, so I'm going to talk for another 2 minutes. Does the stage of endo make a massive impact as stage 4? Look, Amber, many women with endometriosis fall pregnant, and many more with endometriosis don't fall pregnant, and that would be a general statement. I think if you exclude everything else and you haven't fallen pregnant, and you've done IVF and you haven't fallen pregnant, I think it's important that at least at some point the discussion with your fertility specialist has been to remove the endometriosis. My preference is for endometriosis to be treated. Okay, and endometriosis is one of those surgeries that's very difficult to do well. It requires years of extended training, an aptitude to do it, and difficult surgery to get right. So that's the next thing I would say is, yes, it can, but shouldn't put you off trying to get pregnant. But if it's taken too long, or you've had a failure or two, then you should seriously have it considered removing it. Okay, and that's one of the options when I see patients at the start, is to have it considered for removal anyway. Okay. All right, thank you very much for tuning in, and I hope you have the rest of the lovely evening. If you haven't had your dinner, I'm sorry I've kept you so long. Thank you.